Alright, so we're going to start the pelvis and the upper femur. So hip and proximal femur, we've already gone over the foot, the leg. So we have the femur, proximal femur, you have your pelvic girdle, your SI joint, sacroiliac joint, your hip joint. The head of the femur fits into the acetabulum and creates that hip joint. And then you have the symphysis pubis that joins the two parts of the pelvic girdle. So your proximal femur, you have the head of the femur, this little indent right here that we've talked about, the fovea capitis. We have the neck of the femur. We have the greater trochanter here, the lesser trochanter on the inside. We have the body or the shaft of the femur. You're seeing an anterior and a posterior view of this proximal femur. So angles of the proximal femur, as we should know by now, the femur doesn't come down in a straight line. It actually creates a 5 to 15 plus or minus 10 degrees from a straight line down to the midline shaft of that femur. Also, the neck is 125. It shows a 125 degree angle here from the neck through the pelvis to the femur shaft. So also you're looking at a 15 to 20 degree angle right here on that greater trochanter to the femur and the wing of the ala there. So neck to the shaft is 125 degrees. So neck to the shaft, 125 degrees. Longitudinal is approximately 10 degrees. And then an anterior angle, this anterior angle is about 15 to 20 degrees. So we have two hip bones. We have the os coxae and the innominate bones. So os coccyx and the innominate bones. So we have the sacrum and the coccyx. So hip bones, you have three parts. You have the ilium, which is one part. You have the acetabulum, which is right here. You have the pubis bone, which comes down here, and then the ischium. So the ilium, ischium, and the pubis create that acetabulum right here. Okay, so your acetabulum here, your acetabulum right here. This is the head where the head of the femur inserts in, so that's the acetabulum. The hip bones, ilium is up high. The pubis attaches to the symphysis, and then the ischium. So those three bones make up the hip bone. The ilium that we're going to talk about, we have the iliac crest. That's where we palpate. We have the ala, or the wing of the ala, a wing of the ilium right in here. Right in here. They're calling this part the body. Okay. We have the posterior iliac spine. So posterior superior, posterior inferior. Okay. So we have two spines in the posterior. So posterior superior, posterior inferior. We have an ASIS, which is the anterior superior, so superior portion, anterior superior iliac spine. We also have an inferior iliac spine, so anterior inferior iliac spine. And then of course the acetabulum, where the head of the femur fits into the socket there. So anatomy review, this this corresponds to the picture prior, so just make sure that you use this as a label so you can go ahead and label these and know what they are, what they make up, so you can label them on a critique exam. So your anatomy review, You have an anterior and posterior. So here is your greater sciatic notch, okay? You have an ischial spine. You have a lesser sciatic notch. So a greater sciatic notch, a lesser sciatic notch. An ischial spine. And then you have the ischial tuberosity, okay? So the ischial tuberosity here, you have the lower body of the ischium. You have the ramus, so you have a inferior ramus, superior ramus, acetabulum. The upper body, so pubis, the pubic bone. We've got the pubic symphysis, symphysis pubis right in there. You have your obturator foramen. So the whole open holes there, obturator foramens. You have an ischial spine right here, and you will be able to see those on a radiograph. So an ischial spine. You have your superior ramus here, inferior ramus, so superior ramus, inferior ramus, and then the body, which is part of that acetabulum. So the body's part of the acetabulum, inferior or superior ramus, and inferior ramus. Obturator foramen on the lateral view right there. So bony topography, we know some of it. So we have crest of the ilium that we palpate. So the crest of the ilium, we have the ASIS, anterior superior iliac sign, that we palpate. We do not palpate the pubic symphysis. We do not palpate the ischial tuberosities. We can, however, palpate a greater trochanter. Okay. We also don't palpate for ischial tuberosities or any of the inferior spines, inferior tuberosities as well. So crest of the ilium, the iliac crest, ASIS, anterior superior iliac spine, and the greater trochanter are landmarks that we palpate to line up our central ray. So topographical landmarks, this should look familiar from the very beginning. It continually comes back. So make sure that you know that 1 is your xiphoid process, which is at T9, T10. 2 is your inferior rib margin, which is at L2, L3. You have 3, which is your iliac crest, and your iliac crest corresponds to L4, L5. And then your ASIS. Number 4, the ASIS right here, that corresponds to S1, S2, sacrum 1 and sacrum 2. So a true and a false pelvis. So a plane through the brim of the pelvis divides the pelvic area into 2 cavities. Okay, a false, which is a superior, and true, which is the inferior, forms the actual birth canal. So if you draw a line through this pelvis, you have the greater false pelvis, and then you have the lesser true pelvis. And this here, as you see, is the brim of the pelvis, okay? So brim of the pelvis, and then you have your greater pelvis and your lesser pelvis. So greater pelvis is false pelvis, lesser or the inferior is the true pelvis, which forms the actual birth canal. So true and false pelvis, outlet, inlet. Okay, so plane of the inlet, you can see that divides it here. So your inlet is up here. So this is your inlet. This is your outlet down here. So as you see this pelvis here, this is your outlet plane. Okay, so this is the outlet portion of the pelvis, and this is the inlet portion of the pelvis. So the inlet is up high, the outlet is down low. You have that open cavity there. So the inlet is the superior aperture, the oblique plane defined by the brim. Okay, so the brim. And then the outlet is the inferior aperture down here, defined by two ischial tuberosities and the tip of the coccyx. So these ischial tuberosities here and the coccyx. So the coccyx to the ischial tuberosity, that's the plane of the outlet. So your birth canal, it's the path of the baby, the pelvic inlet, the mid-cavity pelvic outlet. So the outlet here, you can see this outlet. So it is defined by the coccyx and the ischiums, the ischial tuberosities. Okay, so the ischial tuberosities here. So this is the inlet of the pelvis, and then this is the outlet of the pelvis. So the baby sitting in the sac here will come down to the inlet and then out through the outlet. So in the past, cephalopelvimetry was a procedure where they measured the inlet and outlet in baby's head via x-ray. They don't do that anymore. They use ultrasound, but they used to x-ray female patients that were pregnant to determine the size of the inlet and outlet to make sure that the infant was going to be able to pass through. But they do that all now by ultrasound. So you can see here in the birth canal, front and side views. So side views, front view. The baby's head is lying right at the inlet. Here it is at the inlet and then proceeding to and through the outlet. So those are the, that's the passageway for the infant, and ultrasound is going to determine the size of that and then the size of the baby's head to make sure that everything is going to work out right and they don't have to x-ray them like they used to. So differences. So we have differences in the pelvis. So general shape for the female, it's usually wider, and the ilia is more flared and shallow. So you can see the female pelvis, it's more wide, it's a little flared and then shallow, okay? And then it is greater than 90 degrees. So it creates an obtuse angle greater than 90 degrees. So the male patient, or the male pelvis, is narrower and deeper. So it's a smaller inlet, smaller outlet. Its angle is less than 90 degrees, so less than 90 degrees, and a lot more narrow, so less flared. Angle of the pubic arch, these are what you're gonna have to keep these in mind. So female is greater than 90 degrees, male is less than 90 degrees. The female is larger and rounder, and the male is more oval and more of a heart-shaped pelvis. Okay? So male versus female, identify male and female pelvis, compare the three characteristics or differences. So make sure that you look at these A and B. See if you can determine which one is male or female and why. Compare them back to the book and then compare them back to the characteristics described prior here for male and female. And that will help you determine going forward which one is male, which one is female. So this one here is more narrow. So this is actually a male pelvis. And then this one here is more round, more flared. This would be your female pelvis. So an axiolateral axiolateral inferior superior projection. So this is for a possible fractured femur. So make sure that you know the entire name, axiolateral inferior superior projection. So it's an axiolateral. So axial is angle, lateral from medial to lateral, and then inferior superior, you are imaging from inferior to superior. You're placing your cassette angled with the head or the neck of that femur. Okay, so your cassette is pushed into the side of the patient just above the iliac crest here, and then this angle is the same angle as that neck, so it runs parallel with the neck of the femur. And when you make that image, this is what you're going to end up with. Hopefully you end up with a better femoral head and a little bit more of that acetabulum is what you're going to want to image. So in your book, there are labels for these. Make sure that you know what these labels are. Use this picture for labels. You may need to label this image on your image critique. So make sure that you know how to label and what they are. So practice, practice, practice labeling. Once again, right here, inferior, superior, so you've got the acetabulum, you've got the head of the femur, you've got the neck of the femur, you've got the greater trochanter here, you've got neck and then body of the shaft, so body or shaft of the femur. So here's your shaft of your femur, here's your inferior ramus, and this would be an inferior ramus as well. So just make sure, like I said, look back through the book so you can label those pictures if need be. So your sacroiliac and symphysis pubis joints, it's a coronal view, so you're looking down into the inlet part of the pelvis. So you're seeing your SI joints, your sacroiliac joints, which are joints that connect the sacrum to the ilium. Hence, we have sacroiliac joint. We have the interpubic disc right here, and that symphysis pubis. So the symphysis pubis joint, pubic symphysis, either one of those, just so you know what those joints are, where they are, what they're connecting. So here's a little table of the joints of the pelvis. So the movement, the joints, you have the SI joint, sacroiliac joints, synovial, amphiarthrodial, limited movement. The hip is synovial, diarthrodial, spheroidal. Your symphysis pubis is a cartilaginous joint, amphiarthrodial, and limited movement. It has some movement because it will separate and allow movement during childbirth. And then the union of the acetabulum is cartilaginous, synthiarthrodial, and then non-movable. So that's the union of the acetabulum where those three bones join to create the acetabulum. So here's some hip localization methods. So it's methods just to use as far as understanding how many inches away that you are. So X is your ASIS. So your ASIS is right here. Okay. So 3 to 4 inches down is the neck, and then medial 1 to 2 inches. Okay, is the neck. So method 1, you have the head, which is 1.5 inches distal and right to midpoint between ASIS and pubic symphysis. So pubic symphysis, ASIS, 1.5 distal to the right is the head of the femur. So the neck is 2.5 inches distal and right to midpoint between ASIS and pubic symphysis. So ASIS, pubic symphysis, that's where you'll find the head, you'll find the neck. So these are just to help you with finding that head and neck. The best way to find them is to find your crest, your ASIS, and then a slight movement in your femur for the greater trochanter. Just know you can't move the greater trochanter or the affected hip, but you can move the opposite hip here, and then just kind of eyeball a line straight across is going to give you the greater trochanter, and then you're going to want to be between the greater trochanter and the ASIS is where that neck is going to be. So that's where you would line up for your central ray for your cross table hip. So they're showing you here again, so femoral head and neck localization. So ASIS 1 to 2 inches, and then 3 to 4 inches down is the neck right across at the greater trochanter. So that kind of gives you an idea. And if you find the greater trochanter, you are right at that pubic symphysis as well. So just some ways to localize the pubic symphysis, the greater trochanter, the neck of the femur for imaging purposes. So your topographical landmarks, this image is the same image as what started the first chapter. So get familiar with them again. Lower abdomen and pelvic landmarks, so your iliac crest is at L4 and L5. ASIS is S1 and S2. So 5 is your greater trochanter. So the greater trochanter is like right at the pubic symphysis. 6 is the pubic symphysis, and then 7 is the ischial tuberosity, which is just underneath that pubic symphysis. So the ischial tuberosity right there. So a hip is seen in anatomic position, a true AP of knee, leg, and ankle, but not of hip, okay? So this is a true hip in the anatomic position of an AP or a knee, the lower leg or ankle, but not of the hip, okay? So this head is 15 to 20 degrees anterior, okay? So we'll talk about why this is important when we do a hip image. So here's our lesser trochanter. And when you do a hip, knee, leg, and ankle, you're going to see your greater trochanter and your lesser trochanter. When we do a hip, what we want to do is we want to hide these lesser trochanters, accentuate the greater trochanters, which means that we turn the feet in 15 to 20 degrees. Okay, so they're going to be turned in 15 to 20 degrees. These lesser trochanters are going to hide back here, and the greater trochanters are going to be better visualized. So just like this is a right hip and leg with the internal rotation of 15 and 20. You cannot see the lesser trochanter, but you can really see this greater trochanter. Okay, so this is what we want. If this foot is laid out, what we're going to deal with is a little bit of the greater trochanter and a little bit of that lesser trochanter. So we know that if we see something like this, that we have forgotten to turn our feet inward 15 to 20 degrees like this here to better visualize the greater trochanter and hide that lesser trochanter. So an internal rotation is what we want for the pelvis and the hip, if at all possible, and then the external rotation is something that we want to avoid unless it's labeled on the orders that they want to see an internal and an external. So anatomic position, we're seeing anatomic position, feet in the air. We are seeing our lesser trochanter. We're seeing our greater trochanter. So this is an anatomic position where the lesser trochanters are visible. Normally they want these feet turned in 15 to 20 degrees to completely hide that lesser trochanter and better visualize that greater trochanter. Okay? So external with external or relaxed position. If you image this way, feet are just relaxed out just a little bit. You're going to see that lesser trochanter really, really well, and you're going to hide the greater trochanter. So if they're wanting external rotation, a relaxed position, and an internal rotation, this is what your external rotation will look like. You're actually doing it to view the lesser trochanters. True AP position, so true AP, you are rotated in 15 to 20 degrees on those legs. So feet, heels come apart, and then toes rotate in 15 to 20 degrees. You're hiding your lesser trochanters. They're not visible. You're accentuating the greater trochanters. They are more visible. Okay? So asymmetric rotation, which means a possible hip fracture. So if this patient cannot rotate this leg in, you're just going to have him bring this one up and rotate it in. So this one should be in. This one you're going to leave where it is. The affected limb with the lesser trochanter is in profile, and it's usually a fracture right here in the neck. So even if they can't rotate the affected leg in, make sure you bring this one up. Either put it in the AP position or rotate it in for the true AP position. And this is usually what you're going to want to do because you're going to want to hide this lesser trochanter. So rotate this one in, leave the affected leg alone, and make your image of your pelvis to see if you can visualize any kind of a fracture. Alright, I'm going to end the video there, and we'll pick up and continue on with some positioning guides of the hip and pelvis.